I said it was only 2 years, not 25 years. It was like yesterday. And believe me, Khalid, I enjoy every bit of a second of this journey. Thank you very much for it. I'm very honored and pleased to be the chairperson with my co-chairperson, my dear colleague and Professor Yossi Rosto, Professor of Technical Oncology at Alexandria University. I am very honored to present my first speaker. Is a known figure all over the Arab countries. He is Professor Fadi Guerra, Professor of Radiotherapy Oncology, American University of Beirut, Lebanon. He will talk about challenges on radiation therapy for carcinoma of the uterine cervix. Please, Professor.
Thank you, Mr. Chairman. I also thank you for the organizers for inviting me to be part of this tradition. I'm very pleased to be here with you. It's always a pleasure to come to Cairo. My topic is reviewing with you some challenges in the management of carcinoma of the cervix. It's primarily from the radiation standpoint, but obviously when we talk carcinoma of the cervix, we have to include some chemotherapy questions. This is the outline, and believe me, I will make it on time. I will not exceed my time. I will start by defining the standard of care of today and touch on the role of imaging in our practice, role of IMRT for the first part of pelvic radiation therapy, and then what is the best chemotherapy that we need to use in our patients? Do we need adjuvant chemo? And there is a question that I hesitated to keep on the talk because there is a talk on SBRT, but I will touch on it a little bit, and then some words on surgery after chemoradiation, because some people are still suggesting to do surgery after all this treatment. So what is the standard of care? This is not a medical student course or resident course, but just to remind the basics. Here we are not talking about early stage disease, we are talking about the disease that are coming for radiation therapy. These are the diseases that's 1B2 and beyond. The first part is always the external beam radiation therapy to the pelvis. The dose is 40 to 45 gray. I personally prefer 40 gray because I don't like to treat gross disease with 1.8 gray per fraction. This is just a old teaching and I like it. Concurrent weak cisplatin chemotherapy at this dose is the standard of care of today. I know NCCN includes 5FU, but nobody is doing it. It's only cisplatin weekly. We follow typically by uterovaginal brachytherapy, and these are the doses here. High dose rate, you can also use low dose rate, of course, and you have to translate the total dose to about 80 to 85 gray to 0.8. This is how NCCN is wording it. No concurrent chemotherapy during the brachytherapy. This is very important to keep in mind for the young generation. Do not use concurrent chemo while the patient is getting high-dose brachytherapy. It could be very toxic. No role for surgery after full-dose brachytherapy. This is also very dangerous, not only toxic, dangerous, and people can die from it. And the question of adjuvant chemotherapy, there is no strong level 1 evidence. Some people are doing it, sometimes we do it, but there is no standard for the use of adjuvant chemotherapy. This question is being investigated in clinical trials. So what is the role or what is the situation of chemoradiation? We know from many trials and meta-analyses that chemoradiation is superior to radiation therapy. This is a given. Everybody believes and agrees to it. And it is superior to radiation therapy alone. Nobody is doing radiation therapy alone nowadays, at least when chemotherapy is available. And how does it compare to surgery? There is no real comparative studies, and we will never have one. But I just, for the sake of comparative values, or I would say comparative images or levels of survival, I put the trial here by the GOG 141, where the questions were neoadjuvant followed by radical surgery or radical surgery, and there was no difference in this trial. just to give you an idea about the magnitude of survival for the patients who come for chemoradiation. Those patients were in the stage 1B1, 1B2, 2A, 2B. And some of them actually received adjuvant treatment. So if you transpose this level of survival to the curve I showed you earlier, you can see that chemoradiation therapy is actually as good, if not better, let's say as good as surgery. And nowadays, in our practice, in many practices, surgeons, when they feel that the disease is somehow advanced, they don't venture and do surgery. They refer the patient for chemoradiation because they are strong believers that chemoradiation can do as well as radical surgery. Now moving to what we do with imaging, how modern imaging is helping us. Just very brief on PET scan, which is typically used for the investigation of lymph nodes and occult metastases that are not visible by conventional imaging. It can be used for staging, which is very important, for interim assessment during treatment, and I will talk very briefly, and evaluation of response, which is typically at 3 months. If you do it before 3 months, you may run into false positivity. So what's the value of this? For staging, the sensitivity is reasonable, 75%, but it's excellent specificity, 95%, and therefore PET scan is recommended in the staging whenever PET scan is available. We do it routinely. For interim assessment, it's not good. It's poor predictor. The response, the immediate response during chemoradiation on PET scan is not really predictor or predictive, at least not consistently predictive, and is not typically recommended. For evaluation of response, it does correlate with progression-free survival and overall survival. It is therefore optional. Why I say optional? Because we don't always need it. Because when we finish the treatment, we just wait for the patient to see how she's going to do. We don't have to just keep doing PET scans. We just follow it with conventional imaging. Sometimes when we have some weird findings on conventional imaging, we go with PET scanning. MRI is also important. I believe the best staging is clinical. Gynecologic oncologists should be able to stage the patient clinically, at least for the local disease. A GYN exam is very important, and it is actually the basis for the FIGO staging. This MRI is showing parametric extension. This is where the tumor is actually breaking the plane as going to the perimetria. You don't see much more than that, but when you examine, you can feel more. And actually, when you combine MRI with physical exam, you can have excellent results. You can also use it for lymph node staging with very good specificity, as good as in literature as PET scanning. This is on the right side where you can see parametric extension and also bilateral lymph nodes involved. So MRI is also now part of the basic staging for carcinoma of the cervix. It's actually more important in earlier stages than in stages that come for chemoradiation. But overall, it is required and it helps in the staging. So now back to radiation therapy. What is the role of IMRT for pelvic radiation therapy? IMRT is a buzzword. It's a technology that's here to stay. It's really very helpful, but we have to use it with intelligence, because it is expensive, although it's coming down in prices, it's becoming more available. You have to know where we are targeting. You have to design your field, or actually to contour your design and your organ at risk and your GTV, gross tumor volume. Here you have the lymph nodes, the uterus and the cervix, the rectum and the bladder, and the bowel. You need to, and actually when you look at the pelvis, once you contour your disease target, you see that it's like a U shape. And you have to ask your beam, your X-ray beam, which is not a laser beam, to come and curve itself inside this U shape. It is technically very difficult to have. You will see something like this. You have a dip into the bowel bag, as we call bowel bag, or the bladder area, but it's not as clean as you would like to. It's not easy to have an IMRT that goes straight into the lymph nodes and the primary area without going into the bowel and the bladder. The yellow is 70%, so you have the 70% dipping, but then the lower energy, lower dose isodoses are not dipping anymore. It is good, but it's not an excellent tool for routine use. And it has been studied. This is the RTOG-1203 published last year at Astro that looked at IMRT for the pelvis. It was in the post-op setting, which is more important because you have more bowel in the pelvis. And look at the differential between IMRT and conventional four-field. This is a bowel function score. This is a composite score that they designed for the study. And the numerical differences is very low. So it's not really a panacea. It's not really something that you feel it's going to bring you a lot of improvement. But yet, if you look at statistics, it is 0.04. It's actually not bad. But it's not really a panacea. We have to keep it in mind. So if you don't have it, don't have a problem, it's not the IMRT of the head and neck cancer where you have absolutely to use it. Here, it's optional. Other pitfall with IMRT is organ motion. So you have designed and contoured your field and everything, your PTV, but then when you look at the progression day to day, look at the motion of the uterus during the treatment. It's actually going up and down depending on the fullness of the bladder and rectum and the position, etc. So it's not, you have to keep this in mind, unless you are using adaptive therapy, then it's really a problem. You really sometimes can hurt your patient by applying tight IMRT for these cases. This is the documentation about the interfraction motion. And there is also tumor shrinkage. You start somewhere, the carcinoma of the cervix is very sensitive and chemosensitive. And when you are week 4, most of the disease is gone. So your design of the field of the GTV has really vanished and no longer applicable. So you have really to be careful when using IMRT to either readapt your treatment or at least use IGRT and adjust your treatment fields. So a few words about chemotherapy. I'm not going to dwell on it, but just to tell you, this is what we do, and I hope you agree with me that all studies that looked at doublets and other than cisplatin has not really shown very much difference. We have done our own study in our institution looking at paclitaxel versus cisplatin. Also, we found no difference, actually, with more toxicity with paclitaxel. This is from other groups with tirapazamine, showing that there is no difference, surprisingly and disappointingly. And this is from India with more drugs, and there is no difference. Now, there is a meta-analysis with the doublets of cisplatin that claims that doublets is better than cisplatin, but I don't think this is very reliable because this meta-analysis, if you are familiar with it, included retrospective studies. And if you remove the retrospective studies, then these are the most important ones pushing for the favor of the doublets. Then if you remove those, the difference will no longer be significant. So I think in essence, cisplatin alone remains the gold standard of the day. Do we need adjuvant chemotherapy? One study from Latin America has really thrown a very problematic question to us, showing that if you add chemotherapy with gemcitabine based after chemoradiation and brachytherapy, you can improve survival. The problem was this, there is toxicity, and also that the chemotherapy was not the same as the chemotherapy used during the chemoradiation. So it is actually important to keep in mind, but it's not a model that we can use in day-to-day practice. There is also a study from Thailand that did not look really at adjuvant question. Although the study showed some benefit from chemotherapy, it was not only for the adjuvant, it was also for the concurrent. And there is currently a study by the RTOG and also by groups in Australia and New Zealand looking at this question, testing the value of adjuvant chemotherapy after full course of chemoradiation with brachytherapy. So I think this study is still accruing. We will have the answer to that later on. Can SBRT or IMRT technique replace brachytherapy boosting of the primary disease? We cannot talk about it today, so I'm not going to dwell on it too much, but to tell you that there is some difference between both techniques. And I personally believe, I'm not going to make a lot of conclusion, but I personally believe that brachytherapy has an edge. So whenever you have brachytherapy available, I would recommend to use brachytherapy. If brachytherapy not available, then SBRT is a good replacement. And I hope we'll hear more about it in the coming talks later on today. This is how we do brachytherapy. I mean, this is very simple and very straightforward. Not simple, not very simple, but you have to know your dose limits and etc. and use good imaging. Here you have CT scan, but you can use also MRI scanning and develop volume-based brachytherapy prescription. This is very important. This is something that becomes very fashionable and developed. This is how the isodose looks like. You are all familiar with it. So, and there is some data, all retrospective, stating that brachytherapy, whenever it's used, you have a superior survival. This is retrospective, but the expert in the field always claims that brachytherapy is not optional, and whenever you have brachytherapy available, you should use it. So I sound very proponent of brachytherapy, and I am, but I think it is difficult to have brachytherapy everywhere. If you don't have it, you can use your external beam tools. So I will close by saying a few words about surgery after chemoradiation. Again, if you have chemotherapy, if you have brachytherapy, you should not use surgery. But if you don't, then surgery may not be a bad idea if the patient is amenable to surgery. This is a trial, randomized trial, comparing chemoradiation with and randomized to brachytherapy or radical hysterectomy, and there was no difference. Although brachytherapy is on top, it's not significantly different. Now, the question that actually very provocative is this trial that looked at chemoradiation and brachytherapy, and CR patients were taken to hysterectomy, simple hysterectomy or no hysterectomy, and there was no difference, although again, no hysterectomy was on top. So this is actually very provocative and very daring. I would not recommend it for my patients. So in conclusion, chemoradiation for advanced carcinoma of the cervix is a well-established standard of care. Single-agent cisplatin remains the best concurrent chemo at present, and the role of adjuvant chemotherapy is not fully established. We have to wait for the phase 3 trial. Brachytherapy is an essential component for local disease control and survival. Hysterectomy is not superior to brachytherapy after CTRT, but maybe an option where brachytherapy is not available. And I thank you for your attention.